All right, good afternoon, everyone. Welcome to the Henry Schein Dental Academy webinar series. My name is Adam. I'll be your moderator. Not going to do my typical spiel today because Dr. Kohltfarber just said this is a very ambitious presentation to get through in an hour. So all I'm going to say is if you have questions, drop them in the Q&A. We'll answer them at the end, and we are not offering CE credit. All right, the floor is yours.
Awesome, thank you. Hi, how is everyone doing today? Or I guess it's probably this evening where you are at. I'm in California, so it's still late afternoon. And yes, as I said, this was an ambitious endeavor to try to do in an hour, TMJ and airway disorders. So we're going to jump right into it. If you have any questions, just let us know, and we'll try to answer all of those at the end. So some of our objectives today, we're talking about some of the presenting symptoms and complaints of TMD as well as airway disorders. Talk about some of the irregularities and key indicators in our Cbct images, and understanding any of the health problems that can arise or persist if our TMD and airway disorders are left untreated. Also, there's correlation between the two. That's why we went ahead and put this together today. And then we want to talk just a little bit about when should you send your patient on for an MRI. And again, ambitiously, I did put some MRI at the end. So this will be really fun. So let's go ahead and talk about obstructive sleep apnea first. So as many of us know, this is going to be kind of a quick review for us, but it's a sleep disorder that involves partial or complete obstruction of the airway space in the presence of breathing effort. It's a decrease in airflow of about 25 to 50%, or cessation of airflow of longer than 10 seconds. And that usually results in arousal from sleep. So when we put all that together, our frequency of events is termed apnea-hypopnea index, or AHI index. It's the most common type of sleep disordered breathing. So there are other types, but this is the most common type. Prevalence in the US for women is between 2 to 5% and 3 to 7% for males, most of which are undiagnosed. And so you probably have a large population in your practice that are undiagnosed. Many of these individuals are part of the obese population, which in America, we seem to be moving that way. And of course, we can look at the severity of it, depending on the number of those AHIs per hour. So 5 to 15 events is mild, 15 to 30 moderate, greater than 30 is considered severe. So OSA is defined as an AHI of 5 or more, plus either excessive daytime sleepiness, or at least 2 of the following: choking, recurrent awakenings, unrefreshed sleep, daytime fatigue, or impaired concentration. And of course, as we all know, our polysomnograms are the gold standard. That's the standard of care for being able to diagnose our obstructive sleep apnea. So there are different questionnaires that we can ask our patient, which is very, very helpful in conjunction with our CBCTs. So one I have here is the Epworth sleepiness scale, and so that might be very, very helpful for us. All of this is going to lead our patient to go on for additional tests. So there are non-mechanical factors that go along with this, but we're just going to talk about the mechanical ones because those are the ones that we can see clinically. And anything from, facial elongation to hypertrophy of hard and soft tissues, high arched palate, we can see retroglossal obstructions, nasal obstructions, and that sort of thing. And so that's really what we're going to talk about today, because those are things that we can see. Now, there's tons of consequences for undiagnosed obstructive sleep apnea. Anything from our coronary artery disease to learning and behavioral issues in children. And I always found that one very interesting. Our kids going through school, if you find that your child or someone complains, that one of their children is having a hard time being able to concentrate in school, and this is actually something to look at. We can see, of course, impaired cognitive function. One of the ones that I recently learned about was the association with increased cancer risk, and it's actually a pretty strong association. Of course, memory loss, I'm a mom to 3 girls. I feel like I always have memory loss, but it could also be obstructive sleep apnea, fatigue. We can see an increased risk of traffic accidents and occupational injuries as well as a result. So there's a whole workup that we want to kind of step through. Of course, a systematic examination, very, very important, reviewing the patient's health history, a clinical examination, and then, of course, imaging, sleep studies. There are at-home sleep studies or in a lab, and then treatment as well as monitoring. So we don't want to just send these patients on with some sort of oral device. We do actually want to monitor them. So looking at the types of imaging, because that's what we can, kind of see as far as the radiological perspective, we're going to talk about the imaging that we have at our disposal. And we have both dental as well as medical imaging that can be useful. And we'll go through each one of these. But of course, our dental is going to be pan or lateral ceph or CBCT. And we're thinking about medical, we have medical CT, and then we have MRI. And let's talk just really quickly about some of the advantages and disadvantages of each one of those. So for our panoramic images, this is by far and away the most common dental radiograph that's out there, readily available. It's very easy for us to take it. It's low cost, low dose. Patients usually love it. And we get a broad picture of what's going on. But our disadvantages, of course, is that we do have distortions with this. We have superimposition of structures. We really cannot see any soft tissue detail and not useful for looking at the airway space. Next, we have our lateral ceph. Again, widely available, very common, low dose, low radiation. We do get a broad field of view to be able to look at. Patients tend to like these as well. We can evaluate all the skeletal types. So from that standpoint, that's very good. Useful in evaluating some oral appliances as well as orthodontic surgery. But the disadvantage is our patient is usually standing or seated. Again, lots of superimposition of structures, and we'd really I'd say limited soft tissue information. We do get a little bit, but very limited. Next, we have our CBCT. Available in dental offices. This is something that's becoming more and more common in more dental offices. We can see the patient in all 3 planes. Very high spatial resolution in comparison to almost any of our other scans. Very, very high spatial resolution, especially compared to medical CT, but also I would say compared to MRI. It has isotropic voxels. What is that? Those are 3D pixels. And for CBCT, our 3D pixels are perfect cube. And so we can see all 3 planes at the same time. It's very different from medical CT, where you technically have more like a brick instead of a cube. And so you really can only see everything really well in one reconstructed section at a time. We have accurate measurements because we have those isotropic voxels. So we have very, very accurate measurements with our CBCTs. It is a lower cost and a lower dose than our medical CTs, much easier to obtain for our patients as well. And it has great metal artifact reduction in comparison to medical CT. Very useful for looking at our oral appliances, orthodontic surgery. There's different patient positions that we can work with. Certainly, the patients in the supine position is what is requested when you're doing any type of research, airway research, to get an NIH grant and that sort of thing. But many of ours in our offices, our patient is actually going to be standing or seated. So that might be a little bit of a disadvantage for us when we're looking at airway space. Poor soft tissue contrast. It does have ionizing radiation. We do still have beam hardening artifacts, even though they're minimal, and we do have an increase in image noise. So we do have a lot of noise in our images. It does scan just the head. And again, many of our CBCTs, the patients standing or seated in our dental offices, to have a supine unit would be difficult for most offices to be able to find that kind of room. All right, moving on to our medical CTs. They are widely available. We are able to see things in all three planes, but again, you're going to have to reformat in a certain plane. We can see good temporal and spatial resolution. I would say that our CBCTs are still probably overall going to be better. It has an unlimited scan volume, goes from your head to your toes very, very quickly. Ideal for airway and bony structures. For airway, the patient would be sitting or laying down, which they're going to be in a medical CT. Excellent soft tissue detail. Very, very minimal noise. So it hits that receptor. It's really going to be 95% signal and only 5% noise. And that's the reason we have the excellent soft tissue detail with our medical CTs. Now, with our medical CTs, we can get different windowing. So we can have a soft tissue window or a bone window. And you'll notice that the bone window looks very much like our CBCTs. In fact, our CBCTs are kind of like I would say a poor man's medical CT with a bone window, because they don't cost as much as our medical CTs do. But this does come at a higher cost to the patient, increased ionizing radiation dose. We do have extensive beam hardening artifacts, so you can see how much beam hardening that we get streaking throughout. And actually, some machines may have a weight limitation to them, depending on where you're at. All right, moving on to MRI. And we're going to talk about this a little bit more when we look at the TMJ images as well. But evaluation of the anatomy in all three planes. We can see that very nicely. A superior soft tissue contrast. So what you're really looking at, I would say, is a soft tissue image. So when you think of your MRI, think of a soft tissue image. The patient, of course, is going to be supine, just like in a medical CT. Excellent resolution of the upper airways. You can accurately measure cross-sectional areas and look at volume. And then there is dynamic imaging modality as well. So you could kind of watch a person swallow and function and that sort of thing. But this does come at a much higher cost. It's not always readily available. It does have a very small confined space. So if your patient is larger or if they are claustrophobic, this might be a hard thing for them because they're going to sit in that machine for quite a while as it's performing all of its imaging. Extensive noise. So you can actually hear the magnets turn on and turn off, and you hear lots of banging and that sort of thing. So it's very, very noisy. Not for use with things like metallic implants, pacemakers, aneurysm clips. We've seen lately, ladies like to have nice long eyelashes, and they can have magnetic false eyelashes. And actually, those little magnets can create quite an issue if the patient goes into an MRI unit. In fact, the magnets can drag through their eye and could actually blind them. So you have to be very, very careful because it is an extremely strong magnet. You don't want to walk in there with any type of metal because it will become a projectile. And weight limitation. Again, the machines are pretty small, I would say. So again, issues with claustrophobia and any of our larger patients. All right, so now we have talked about the imaging we're going to discuss today. Let's start with airway, and we're going to look at the anatomy of the airway space before we start to talk about some of our issues. I think, again, we're looking for any type of a mechanical obstruction when we're reviewing it with our CBCTs. And let's start from the top. So here's our airway space. We have our nasopharynx. Of course, we have our nasal fossa in this region. Nasopharynx, we have our oropharynx and our hypopharynx. Here we can see the base of the tongue. Of course, we have our soft palate, and we've got our epiglottis. And here we can see it from our coronal sections as well. Our adenoid tonsils will be up in the top here. And we have torus tubarius right there. We're going to have our palatine tonsils on either side. This is our oropharyngeal region, and we're going to have our lingual tonsils coming in. So as we're scrolling through, you also in this region will have your submandibular glands, your epiglottis, and this is your laryngeal vestibule. So starting with our nasal fossa and septum, because I think working our way all the way through the airway space kind of makes a little bit more sense to me. Hopefully it does to you too. But of course, we have our nasal fossa. See it very nicely here. We've got the lateral cortical borders of that nasal fossa. And we have our nasal septum. So we have kind of a bony and cartilaginous nasal septum. Now, of course, we know that our nasal fossa has 4 different functions: warms and humidifies the air, removes and traps pathogens, responsible really for our sense of smell, and drains and clears the paranasal sinuses. And we talked some about this at the last lecture that we did. We actually spent quite a lot of time on the paranasal sinuses. And for that reason, I'm probably going to breeze through these just a little bit quicker. When we're talking about our turbinates, we've got our superior, middle, and inferior turbinate. Nice little scrolls of bone, and again, warming and humidifying the air. Up in this region, we have our cribriform plate of our ethmoid bone, right at the superior aspect of that nasal fossa. And here's a little bit more on our nasal turbinates. So we have our inferior, our middle, and you have these tiny little superior turbinates as well. You might see it as our concha or turbinates. Either way is perfectly fine. All right, and then of course we have our maxillary sinuses, which are those air-filled cavities that we talked about quite a lot before. And of course, one of the things always to remember is that we have very, very small sinuses when we are little, and these will go ahead and pneumatize down as we grow and develop, and that gives us the shape of the maxillary bone. As it grows and develops, we have a drainage pathway that will develop. But occasionally that does not happen, and you might have a small hypoplastic sinus on one side or another, and that will affect the development of that sinus drainage pathway. And here's our sinus drainage pathway. This is our osteomeatal complex. This is what our ENT is very concerned about. Want to make sure that everything's draining appropriately for the patient. And we've talked about these before. We really don't want to block the ostium, or that osteomeatal complex, that whole drainage pathway, or else the sinus can actually act like a pathological cavity in and of itself. So, of course, blockage of this is going to affect our ability to breathe, at least through our nostrils. Next, we do have our palatoglossal airway space. So here's our tongue. Here's the palatoglossal airway space. Here's our tongue right here. Now, some patients might have an enlarged tongue, so definitely something that we would want to think about or look at. Make sure that they don't have an enlarged tongue. And of course, sometimes when the patient is sleeping and everything is relaxed, the tongue may slightly relax back. And we've got our nice little soft tissue, our soft palate right here. You can see that. And you can see how interconnected everything is. Our nasal fossa with our nasopharynx, with our oropharynx, with our hypopharynx. Everything is very, very connected in here. And so if we have an obstruction at any of these locations, that patient could have difficulty breathing. Now, one of the things we also want to kind of pay attention to is that when we are segmenting out and measuring the airway space, we tend to want the patient to be as relaxed as possible with their tongue. Now, usually we have them biting an MIP, and we have their tongue just kind of relaxed against the lingual aspect of those anterior teeth. And then, of course, we can have a really, really nice image of what that airway space might look like. However, sometimes we kind of forget, and we'll tell the patient, go ahead and put your tongue up to the roof of your mouth, just like we would for a pan. And what that does is push all of those all those soft tissues posteriorly, artificially, I would say, and it gives us an erroneous airway segmentation and airway measurement. So definitely something to think about when we are imaging these patients. We don't want to tell them to put their tongue up to the roof of their mouth like we would for a pan, but that tends to be a very common thing that we see. Okay. Right. Our nasopharyngeal airway space, we're going to start with that next. And we're right up here at the top. Again, this is our nasal fossa. This is our nasopharyngeal airway space. And we can see in this particular image, our patient's nose is up. And we've got a couple of things here. So let's go ahead and talk about them. We've got this little outcropping of tissue called the torus tubarius. We have drainage of the eustachian tube through the sinus of Morgagni, just anterior to that. And posterior to that, we have the fossa of Rosenmuller. And this is a very special little fossa. This actually is a board question because this is where nasopharyngeal carcinomas like to hide. So you can easily see that. Right, our oropharyngeal airway space, moving on down, we can see that very well. This typically tends to be the location that we'll go ahead and measure. It tends to be where we have our minimum cross-sectional areas. What we found is that our medial lateral dimension is probably more important even than our AP dimension. And so way back before we did airway segmentations and automatic measurements, we did this all manually. And we found that if the medial lateral dimension is smaller than 14 millimeters in a male or smaller than 10 millimeters in a female, we would go ahead and call that a limited airway space. In the AP dimension, if it's less than 4 millimeters, we would call that a limited airway space. And of course, the posterior pharyngeal wall as well. We can see that very nicely. Now, it's important when we're imaging our patients and we're wanting to do airway segmentation that we actually capture the posterior pharyngeal wall within our field of view. If we don't capture that, we actually cannot do automatic segmentation on the airway space. So you need to be able to capture that. But we can also see things like little osteophytes and that sort of thing, or partial ossification of the anterior longitudinal ligament. And that may actually affect the stenosis of that airway space. So definitely something to look for. And moving on down, we have our hypopharynx down in this region down here. So here's our little epiglottis. This patient's nose is up in this particular software. So this is just anterior to the epiglottis, and this is our little vallecular space. This is also another little kind of danger space because this is where our squamous cell carcinomas like to hide. So if we say gross asymmetry in these areas, we definitely need to send these patients on for additional imaging because we really can't differentiate the soft tissues with our CBCTs. All right. Our airway measured. Let me go back. So when we're measuring out our airway space, we talked roughly about some manual measurements that we used to do before. We can also look at the collapsibility of some of our soft tissues as well within our nasopharyngeal region. And we can segment out the airway and look at our minimum cross-sectional area, which is what we'll want to do. Now, according to the research that has been published, it's found that an upper airway size of about 40 to 67 millimeters squared is the smallest cross-sectional area in adults that has been shown to be associated with obstructive sleep apnea. So in the literature, it's actually found an association with that. When I'm looking at this as far as my CBCTs that I'm reporting on, I'm a little bit more generous. So I'll say if it is 100 millimeters squared or smaller, that we have a limited airway space. And the reason that I went with that number was a couple of things. First of all, we're seeing more and more of the software that's coming out, showing us beautiful color maps, but they correlate to something different than 40 to 67 millimeters squared. And so they don't always correlate with what the research says. And, in talking with people and with the developers, they said, well, we're just casting a little bit wider net. And I see no problem with that. I think that's a really good idea because we are not diagnosing obstructive sleep apnea. We're letting the patient know that they have a limited airway space. And then that kind of opens up a conversation with Mrs. Jones, allows us to talk about some different things with her, maybe she's more open to going and having a sleep study now after she can see what her airway space looks like. And so from that standpoint, I think that, being able to kind of quantify these things for our patients really smart. So if it's 100 millimeters square or less for the minimum cross-sectional area, I'm going to say that is limited. If it's between 100 to 150 millimeters squared, I'm going to say it's normal, but it's on the small side of normal for that patient. And I still think we probably should go through some of the questions and talk to Mrs. Jones about that. Now, is that to say that if it's a larger airway space, it's not going to correlate with obstructive sleep apnea? No, that's definitely not the case. We see a huge variety in what comes through. In fact, some of our patients that have already been diagnosed with obstructive sleep apnea may have a huge airway space when they are sitting up and awake during the daytime. It's just when they lay down at night, they don't have the musculature to be able to keep everything open. So we know that these are just rough guidelines. We're letting this technology help us to aid Mrs. Jones in finding out whether she has obstructive sleep apnea, but our CBCTs cannot diagnose obstructive sleep apnea. That's got to go on. The patient's got to go on for a sleep study because, again, that's the gold standard. So I do want to make that really clear. But what I would also do when you are looking through your CBCT is look for our anatomical variants and pathologies that are limiting the mechanical airway function. And let's talk about some of these. So starting in the nasal fossa, we can have pneumatization of the middle turbinate. This is known as a concha bullosa. This is considered a variation of normal. Typically, we think we don't need to worry about this. In fact, we may not even mention it because it is considered normal. But it could cause narrowing of the middle meatus. And so if the patient is complaining about breathing issues, this is one of the things we'll want to go ahead and mention, that we have a concha bullosa. We can see variations in the size of the turbinates, and sometimes that can cause people some concern. They think, well, maybe we've got some congestion on one side versus the other. Well, actually, it's very, very common to see changes in the sizes of the soft tissues during the day. So, for instance, if you were to image Mrs. Jones in the morning, you'll notice that this inferior turbinate is larger than the other side. If you were to image her in the afternoon, it would be the opposite. And this has to do with our normal diurnal variation or the normal fluid flow in our body throughout the day. We can also have a deviated nasal septum. Actually extremely common. About 80% of the population has some sort of a deviated nasal septum. It's actually more rare to have a straight nasal septum. But sometimes we can see, for instance, we've got a deviated nasal septum and we've got quite a bony spur. So this can decrease the airflow on the affected side. With this particular patient, if they're complaining of breathing issues, we might want to go ahead and send them on to ENT. Now, certainly we can look at this clinically. You can have them close one nostril and try to breathe, and then close the other nostril and try to breathe. And if they're having difficulties breathing on one side or the other, then we go ahead and send them on for additional evaluation. We can also see hypertrophy of our inferior turbinate. So right here, we definitely have hypertrophy of that inferior turbinate. You might look at that and say, wow, we've got a lot of congestion there. It could be congestion, or it could just be that we have an enlarged turbinate. Again, hypertrophy of the inferior turbinate. But definitely it is decreasing the airflow on that side. And in this particular patient case, we can also see enlargement or hypertrophy of the choana as well. So that's just that posterior aspect of that turbinate. So definitely they're going to have issues with breathing on that particular side. We can also see little nasal polyps. You can see a couple little nasal polyps in here. Almost looks like little grapes, doesn't it? So a little kind of teardrop or grape-like. But these are a result of chronic inflammation. We can see this with allergies, infections, asthma, that sort of thing. But they can also obstruct the maxillary sinus ostium. Now, small polyps tend to be fairly normal, maybe not a problem, but larger ones definitely can obstruct the airway space. And we usually do mention these. In fact, some of these we might, especially this size, you'll probably want to go ahead and send it on just to be looked at. Make sure we don't have anything else going on because, again, we can't differentiate those soft tissues. Now, here we actually have a polypoid mass in the nasal fossa. And again, we can't differentiate the soft tissues, so we can't say exactly what it is from our CBCTs. But what we are noticing is it's bilateral. It's crossing our midline. We have erosion of the bony septum, which is not looking like a very positive thing at this point. Definitely the patient's going to have difficulty with breathing. So we're going to send them on to ENT to be scoped out and looked at and have a further imaging because we can't see exactly what's going on. However, this is very important that we're able to catch this obstruction on this patient and send them on. So from that standpoint, CBCT is just so wonderful for your patients. I think it really allows them to have a better picture of what exactly is going on, where in the past, something like this has to become quite large for them to even figure out that they have an issue. We talked a little bit about mucoceles. So if we block that sinus drainage pathway, the sinus can start to act like a pathological cavity in and of itself. It's going to start expanding and destroying cortical borders. And definitely that's going to cause blockage and obstruction. You definitely can see that we're starting to have expansion of these cortical borders of the nasal fossa. And definitely we have an obstruction to our airway space. And sometimes we have polyps that actually start in the almost in the nasal fossa and extend down through our ostium and into the maxillary sinus. So an antrochoanal polyp, definitely we want to send that on. You can see another one here, kind of filling that sinus completely with enlargement of the ostium and extension into our middle meatus and nasal cavity. So again, this is going to be referred to ENT for our mechanical obstruction. When we're talking about our tonsillar tissues, obviously this is an area that we want to look. We can have hypertrophic adenoids. Now, this is fairly common in a child, so this might just be a variation of normal in a child. However, in an adult, we're going to be a little bit more concerned. We're going to start to think about things such as a chronic inflammatory process. We can even get various lesions up in this area as well. Again, we're up in the nasopharynx. So definitely we have some mechanical obstructions that need further evaluation. Now, in a child, if they have enlarged tonsils, we can go ahead and send them to have their tonsils removed, and that can definitely be helpful. So here we have some enlarged palatine tonsils right there. In fact, some of our kiddos can actually have almost, we'll call them like kissing tonsils because they're so large that they're really having a hard time breathing. We can also see, of course, our enlarged adenoid as well. You can see the minimal amount of airway space in this particular region. So this patient needs to have some tonsillar debulking, I would say. Now, we can get acute bacterial tonsillitis. I talked about this a little bit with some of our adults, but we can also get this, of course, probably more commonly with children. And this can become chronic over time as well. So, if the patient is having difficulty breathing, this could actually become quite dangerous. We want to make sure that they're on the appropriate treatment. And if they have persistently enlarged tonsils, we can go ahead and send them to ENT. And I think they actually have a particular number. If they have 4 or 5 episodes in a year, then ENT will usually go ahead and take the tonsils out. Now, when I was a kid, in my generation, they went through a phase where they did not do that. They really felt that you needed to keep all of your tonsillar tissues. And so there's probably a whole cohort of adults that are my age that still have their tonsils. And these can become enlarged and cause issues over time, especially as we start to become more sedentary in life, I would say, and gain a little bit of weight. So definitely something to kind of consider. Lingual tonsils, definitely we can have enlargement of the lingual tonsils. Here we have almost an asymmetric appearance, so maybe an asymmetric hypertrophy of the tonsil on that particular side. Coronal, it's looking a little bit more symmetrical. We like things to be symmetrical, especially when we're talking about some of these soft tissues. The interesting thing with this is they've actually looked at the degree of lingual tonsillar enlargement and tried to identify the high-risk patients. So the research showed that lingual tonsillar tissues of greater than 2.7 millimeters were actually not identified in patients without some sort of obstructive sleep apnea, and or maybe some acid reflux as well. So definitely that's something that we need to look at. Now, if you have sent off one of your kiddos for tonsillar removal, many times what they'll do is they'll remove the palatine and adenoid tonsils, and commonly the lingual tonsils, of course, are left. But things can happen with that. And we've had several cases where they came back, the kid still was having difficulty breathing, went ahead and redid imaging. And what we found is there actually can be a compensatory enlargement of your lingual tonsils. So it's trying to make up for the fact that the other tonsils have been removed. And so it's thinking, oh, we're going to go ahead and enlarge in size to make up for that. So we'll have hypertrophy of the lingual tonsils. It almost becomes more dangerous because it moves your obstruction down lower within the airway space. So if the kid is still saying, hey, I'm having a really hard time breathing, sometimes we have to image them again and see if we might have a compensatory enlargement of the lingual tonsils. So just something to think about. Again, we can have ossification of the anterior longitudinal ligament. So we do have a ligament that runs anterior to our cervical spine. This can start to ossify over time. And you can see that it has displaced those soft tissues anteriorly. And we now have an obstruction within our airway space. So definitely that can happen. And again, things that we want to look for. We can have actual pathologies. We did talk about that. We saw one earlier within the nasal fossa. This is within the nasopharyngeal region. And again, with our CBCTs, we really can't see exactly what's going on. We can't differentiate the soft tissues, but we can definitely see that there is an asymmetric lobular enlargement on this particular side. We tend not to really like lobular enlargements. That's very worrisome for us. So this patient needs to go on to ENT for additional imaging. This is a case of nasopharyngeal carcinoma. In fact, we're starting to lose all of our bone. You can see the erosion of the bone. This is the clivus right here. So it's eroding through all of that. You can see what it looks like at the posterior region of our nasal fossa and within the nasopharynx. So when we have actual tumors, of course, that is going to cause difficulty breathing. And the patient might come to you first thinking that maybe they just need to have an oral appliance. So these are things that you may be seeing. This is an Esthesian Neuroblastoma, also known as an olfactory neuroblastoma. Begins with the olfactory epithelium and a kind of an exuberant or tumor of the epithelium. And again, same thing. We're starting to see loss of cortical borders. It's definitely eroding through, and this is a true emergency. So we'll want to go ahead and send these over to go be imaged and additional treatment, of course, outside of our scope of dentistry. And of course, we know that different skeletal classifications make a difference as well. So we're far more concerned about our class 2 patients than we are about our class 3. So here's our class 2 patient. We can see we have a very minimum cross-sectional area. Our class 1, so our little class 1 right here. And actually, we do have a minimum cross-sectional area with this patient as well, versus class 3, we could probably drive a train through that. So this patient's going to be much less likely to have airway issues. But again, not always. Now, there's a whole host of treatments for obstructive sleep apnea. There's some crazy stuff that's out there. Probably the most common is the CPAP. Many of our patients don't like sleeping with a big mask on their face, and so we can really help them out. But treatments will vary between surgery to various chin wraps. There is, actual psychological therapy, trying to talk yourself through it, or maybe even doing nothing. But the things that we tend to be able to look at in dentistry are possible need for orthodontic surgery, as well as oral appliances. And with oral appliances, I definitely stress that our patients have a professional appliance made in a dental office. There are appliances that you can get over the counter that can cause quite a lot of damage within the temporomandibular joint region. And so I know my little brother has obstructive sleep apnea, and he has a CPAP that he does not like. And he didn't want to go to the dentist to actually have everything looked at properly. So he purchased this oral appliance off the shelf and was able to fix this for himself at home. And after a couple of weeks, of course, his temporomandibular joints were really, really hurting him because it was not placed correctly. So we have to have the condyles in a condylar conformative position. And obviously, that is something that, going through courses and things like that, we know how to do. But it's amazing to me that some of these things are available just over the counter for individuals. They can really do a lot of damage to themselves. All right, so here's some orthodontic surgery example cases. This is a class 2 patient. This was pre-surgery. We saw this one earlier. You see that limited airway space. And then this was our post-surgery with bilateral sagittal split osteotomy, and they had a genioplasty. And we do have a little bit more airway, still pretty small at this stage of the game, I would say. So we might start to think about perhaps other things as well, but we do have some improvement in the airway space, and that might be enough for our patients. All right, here's another example. So this is pre-surgery, and we have a minimum cross-sectional area of 110 millimeters squared, and following surgery, it was enlarged. So definitely this is an option that we can think about for our class 2, our skeletal class 2 patients. This is a patient case. This is a class 3, which typically we have a very large airway space, and we can see that we do have enlarged adenoid. Even post-maxillary advancement, we still have a very, very small airway space, and this patient needs to go on and have their adenoids removed. Here's another case, pre-surgery and post-surgery with another class 3 patient. So they were able to have a little bit larger airway space, but again, we might want to look at some other things as well because it still would be considered a limited airway space. We have nice sleep appliances that we can provide. I like the ones that are the two-way adjustable because we can take the temporomandibular joints into account, which is very, very important. And so let's go ahead and talk about that because we know that there's crossover between the two, between our airway and TMD. And I'll talk about that just a little bit. But we can use certain software. I know I have a third-party software, so I might use Invivo. Another one that I really, really like is our CCAT Air to do automatic segmentations and tell us about the minimum cross-sectional area. That way we're not having to measure things manually. And of course, we do want to follow these patients through time as well. Way back when I used to, when I was a general dentist, I used to place various devices or oral appliances, and then I sent the patient on their way, and I never thought about the temporomandibular joints. But we do know that it is possible for us to cause an issue if we're not placing those condyles in a condylar conformative position for that patient. Here's a great example. This is no appliance, and then this is the increase in the airway space with an appliance added. And you can see definitely a huge improvement in that airway space for the patient. All right, so let's talk a little bit about the correlation between the two of these. This was a cohort study. Maybe I have obstructive sleep apnea and didn't get enough sleep last night. No, there's something called a huge cohort study. This is the OPERA cohort, and they had about 2,600 people within this particular study, and they were ages 18 to 44. And they found with the first study, they end up doing multiple studies on this. The first study, they found that 248 of the cohort developed first onset TMD during the 2.8 years of follow-up. Both of the studies that happened support a significant association of obstructive sleep apnea symptoms and TMD, with prospective cohort evidence finding that OSA symptoms preceded the first onset of TMD. So what does that imply? It implies that our treatment may have caused some TMD issues in the patient. And again, maybe we did not situate the condyles where they needed to be. And so I would always look at the condyles. I would always check the condyles. I would monitor these patients. What they actually found is that we can tend to see osteoarthritic changes within about 6 months. Now, our clinicians will tell us that they can't really tell that there's a change or a problem with the patient unless they complain of symptoms or they start to see occlusal issues. And it can take up to 3 years to see occlusal issues with that particular case. And by that time, there's quite a lot of damage to the condyles. So that's one thing we definitely want to look at, is we want to monitor our condyles and make sure that our treatment for these patients hasn't caused another problem. Now, getting into our TMD, TMD has quite a large societal impact. We know that 1/3 of adults and adolescents have some sort of signs and symptoms of TMD. When we are looking at collective days or work days lost within the population, they say that there is an approximate loss of over 17 million collective work days in the United States caused by temporomandibular joint disorders. Seems like quite a lot, doesn't it? But we see it, not only in adults, but we do see it in children, especially mixed dentition. Up to 25% of our children in the mixed dentition stage can have some sort of popping or clicking sounds. We can also have reduced posterior facial height in our orthodontic patients. With our orthognathic surgery patients, sometimes we can have condylar resorption, and that will result in an anterior open bite and further decrease the airway size. So we can see that these issues really kind of go together. So what's the role of CBCT imaging when we're talking about our temporomandibular joints? By and large, we're evaluating the hard tissues only with our CBCTs. Really what we can see is the hard tissues. We're not being able to visualize the soft tissues, but we can confirm the extent or stage of diseases, evaluate our treatments and see how they're doing. We do need to realize not every patient will require imaging, although nowadays when we have CBCT, it's easy enough for us to look at it and see what's going on. But we do know that there is selection criteria and that sort of thing. Not every patient is going to need it. And again, balancing the effects of sleep apnea treatment and our TMD. So you don't want to forget one and just concentrate on the other. It's kind of something that goes together. We're looking at our anatomy. We have our articular eminence. You see that very nicely with our CBCTs. We can also look at our glenoid fossa region. What we're looking for is nice, thin, intact cortical borders. In fact, when we start to see thickening and sclerosis of cortical borders, then we know that we have a chronic inflammatory process. And so we want to see these nice, thin, intact cortical borders. Moving down to our mandibular condyle, we're looking for, again, smooth, intact cortical borders. It's letting us know that we do have a nice, healthy temporomandibular joint. What we do want to pay attention to is that these cortical borders are not fully ossified until an individual is between the ages of 21 to 22 years of age. And so, if you've imaged an 18-year-old and you're not seeing the cortical borders, it does not mean they're not there. It just means that it's not fully ossified. Those cortical borders are not fully ossified, and we can't visualize it within our CBCTs. So that's something to keep in mind. One of the things that we use when we're diagnosing our TMD is something called the research diagnostic criteria for TMD. There's actually some great papers that are out there. There's a group that is across the United States as well as Europe, and they are working to try to standardize the diagnoses for temporomandibular joint disorders. And so they came out with Aussies Guidelines. And so they had different guidelines through the years, and they actually have questionnaires in their papers. You could actually go to some of their papers and read them and use those questionnaires in your office. So they're trying to standardize the questionnaires and the diagnoses and that sort of thing, which I think is a fantastic endeavor. The Aussies Guidelines, I think, came out in a paper in 2009 by Dr. Ahmad, and it looked at 11 different criteria, 11 different osseous criteria, and then it broke it down into 3 different diagnoses. No osteoarthritic changes, maybe we have indeterminate or adaptive remodeling, or then yes, osteoarthritic changes. And so when we look at all of this, we know that, of course, no osteoarthritic changes, we're going to have nice, smooth, intact cortical borders. If it's indeterminate, we could have articular surface flattening. Or let's say subcortical sclerosis, but that's more of an individual patchy sclerosis. By the time we come down to yes, osteoarthritic changes, we have generalized sclerosis. What's the difference between the two? Well, generalized sclerosis, the body's laying down bone in response to the inflammation. And so the bone's going to look very, very white, very sclerotic in appearance. Where if we have just an occasional small little subcortical sclerosis, it could be something as simple as a dense bone island or anostosis, and it may not be something that we need to worry about. So that's kind of the difference. So we can say that could be indeterminate, or it could be adaptive remodeling. Articular surface flattening is the same thing. So let's go ahead and look at pictures of all of these. So here is our normal condyle, where we have smooth and intact cortical borders. This is a bifid condyle, a beautiful heart-shaped appearance. You know, you just want to send that beautiful picture to your loved one at Valentine's Day. And no, it's really a cool variation of normal. So, but again, intact cortical borders is our key. Then we start to see flattening at the superior lateral pole. It tends to be the first thing that we will see. But again, this is indeterminate for osteoarthritic changes. It could be adaptive remodeling. You'll notice that your cortical borders, they're still there. They're just thinned. When we start to see actual pitting in the cortical border, then we know we have small surface erosions. So these are some small surface erosions. And that might be the very first thing that we see with osteoarthritic changes. So this would be our mild osteoarthritic changes. The next thing we might notice is we've got some bony apposition. So that's bone that's being laid down in response to that inflammation. Again, the body's trying to wall this off somehow. And so we get these little osteophytes, these anterior bony apposition, and it kind of looks like a bird beak pattern. Here we have, well, this is an anterior one. Here we have one on the medial aspect. So this particular condyle, we've got generalized sclerosis. We also have a medial osteophyte. This one we've got, again, generalized sclerosis, anterior osteophyte. Look at the glenoid fossa region. You've got all that thickening and sclerosis of the glenoid fossa region, letting us know we do have a chronic inflammatory process. And we have something that looks like a little cyst. This is actually a breakdown of the bone in response to the inflammation. It's a pseudocyst. It is not epithelial lined. So this is our subcortical pseudocyst. And you might see these under different names. You might see them under a geode or Eli cyst. So you may have learned them under different ways. We can also see that sometimes these little osteophytes will break off. So we can see osteophytes bilaterally on the right side and the left. And this is commonly how we will image it with our software. What you'll notice is that we have a nice measuring tool on the condyle, and then we've taken sections of that condyle. And there's our numbers, and of course, they're going to correlate to our numbers that we have up here. So you'll see this will tell you right 29 or left 25. So, you know, if you're looking at the right side or the left side. And then, of course, we typically have a coronal section as well. Now, we can flip these, and we can do coronal sections with these also. But one of the things you'll notice is we have an anterior osteophyte on the right side. On the left side, we can see that we have a calcification that's floating anterior to the condylar head, and that is an osteophyte that has broken off, also known as joint mice. So if it's one, is it a joint mouse? I don't know. Pretty fun question there. But yeah, we usually call them joint mice. And then, of course, we can see with some of these, we can get some little subchondral pseudocysts as well. Here's another look at them with some 3D models that we put together. This is part of my PhD work, and we looked at it with each of the different imaging resolutions with our CBCTs, as well as our segmented 3D models. And so these are actual models that you could flip around. We created these and then overlaid them with our ground truth, which I'll show you coming up next as well, to make sure that we were actually able to segment or 3D model what we thought we were segmenting and 3D modeling. So here you can see what flattening is going to look like at each of the imaging resolutions and what it will look like with each of the various 3D models made from those CBCTs. And we found that people, by and large, from the 3D models were able to identify disease better. Makes sense when you have a model that you can turn and flip around, it makes it a little bit easier for us. Sometimes with our CBCTs, we're not quite sure exactly what we're looking at depending on the imaging resolution that we have. So of course our flattening is adaptive remodeling. Here we can see what our little cortical erosions look like at each of our imaging resolutions. So nice little pitting within those cortical border. Definitely lets us know that we do have osteoarthritic changes. May or may not be associated with clinical symptoms. And that's the really strange thing with temporomandibular joint disorders, is that we might see the osseous changes and yet the patient has no symptoms at all. Or the patient might come in with excruciating symptoms and yet we're not seeing anything as far as the osseous structures is concerned. So it's very, very multifactorial, and it makes it very difficult for us in treating these patients. Now, if the patient has persistent symptoms and our occlusal therapy or our different appliances are not doing a good job in trying to curb that for that patient, or exercises that we've instructed our patient to do, then we can always go ahead and send those on to orofacial pain. We can also send them on for additional imaging, and we'll talk about that in just a second as well. Here's our anterior osteophytes. In fact, this patient's pretty broken down. These are anterior osteophytes here. This is a lateral osteophyte. So this is our coronal, and these are sagittal sections at each of the different imaging resolutions. And of course, we can see how that correlates to those 3D models as well. We can also see various things, various pathologies. So this is either synovial chondromatosis or chondrocalcinosis. And what you're going to notice is you have multiple of these nodular hyperdensities surrounding the condylar head. It almost looks like, some of our space junk orbiting a planet. And so with our synovial chondromatosis, we get multiple cartilaginous and osteocartilaginous nodules within the connective tissues. The patient can have periauricular swelling, pain, decreased range of motion. Usually they're going to treat this very similar to osteoarthritic changes, but occasionally they'll actually have to go in and remove some of these loose bodies that are in here. Now, chondrocalcinosis can look very, very similar. This is our pseudogout. And we get all of these little calcium pyrophosphate dehydrate crystals. And tend to be finer calcifications than synovial chondromatosis, but that can be difficult for us to tell the difference with our CBCTs. But both of these will be treated the same. This is a particular case. You can see it looks like we've got multiple hyperdensities surrounding that condylar head. And when we get into it, again, we can see these characteristic nodules that tell us, we probably have synovial chondromatosis or our chondrocalcinosis. And we can see these actually in developing over time as well. So this was a patient case where you could see it developing over time. So this is what she looked like in her sagittal and coronal sections in 2020. And when she came back in 2021, we could definitely see, we've got more of these little nodules, these calcified nodules floating within the synovial fluid. And they are growing in size. So we can see a size difference as well. You can definitely see that they're more pronounced than they were the year before, that there's more going on there. And we can see that in our coronal sections as well from 2020 versus our 2021 as well. Now on the other side, we do have an anterior osteophyte that's broken off. So we do have a osteoarthritic changes, but our synovial chondromatosis or chondrocalcinosis tend to be more unilateral. Very rare to have those be bilateral. We can have asymmetry. You might have a right mandibular hypoplasia. So this condyle is very small when I compare it to the other side. And sometimes we're not quite sure if we have a hypoplasia versus a hyperplasia. And with that, I tend to look at my glenoid fossa to kind of let me know exactly what's going on. We can also look, of course, at our mandible. So we can definitely see that the mandible has, decreased size on the right side versus the left side. And so that can kind of help us when we're trying to decide which side actually has the particular issue. So this is a right mandibular hypoplasia. And we can go ahead and measure that out if we are unsure. And that gives us a little bit more concrete measurements to go off of. That, we know how, small the condylar head is on a particular side, how short the condylar neck is on a particular side, and that sort of thing. So that can kind of help us when we're putting those measurements together. This particular patient had quite a lot going on. There's a cleft palate, but they also had a right mandibular hyperplasia as well as temporomandibular joint disease. And you can see how large the condyle looks on one side versus the other side. We can see it in all of our sections as well. So in that, that's in our AP dimension, it's much larger than the other side. You can also have a genesis of the right mandibular condyle. So this was a hemifacial microsomia, and we are missing our right mandibular condyle on this particular patient. So you can see that we're missing the condyle on the right side, but we have it on the left side. You can also see trauma. The most common location is usually at the condylar neck. This was pretty significant trauma. It's actually fractured the condylar head, so it takes quite a lot to do that. But it's going to displace the condyles medially, inferiorly, and anteriorly with the pull of the lateral pterygoid muscle. So the muscles are going to pull and reposition that condylar head or that condylar fragment. Usually symptoms with that, a patient is going to have a history of trauma, and they might have deviation to the affected side on opening or inability to protrude. They might have an open bite, pain, or trismus. So, and of course, if this goes untreated, which many times it can go untreated, the patient, if they're still growing, might have hypoplasia or asymmetry on that particular side because it does not grow properly. So it is important for us to be able to catch these things. And many times this is missed in the ER. So definitely something you want to look at. And here's an image of old trauma on a cephalometric radiograph. And we can see it looks very flattened, almost looks like kind of like a footstool, I would say. And here we can see it with our CBCTs. And so what's happened is that particular fragment was pulled with the pull of the lateral pterygoid plates, or the lateral pterygoid muscle, I should say. And then it went ahead and reattached over time. And so you're actually going to see changes within the glenoid fossa region as it changes to accommodate this new appearance of the condylar head. And so definitely this is our old trauma. All right. We can also see cystic lesions. So here we have something going on. We might say, no, maybe this is a large subchondral pseudocyst. It most certainly could be, but it could also be that we actually have a simple bone cyst. It is possible to have simple bone cysts, also known as idiopathic bone cavities, within the condylar head. And these can spontaneously heal, so we don't tend to do a whole lot with them, which is kind of interesting. Being a whole host of benign lesions as well, so you can get an osteochondroma. This is probably our most common benign lesion. We can also get an osteoma in this area as well. What you'll notice is that we have enlargement of the condylar head internally with our cortical borders still on the outer aspect of it. And here's some more. This is another one that's a possible simple bone cavity or idiopathic bone cavity. We can also get an osteoblastoma. Again, this is still considered benign, although it looks pretty aggressive. What we'll notice again is we have this internal enlargement of the bone. It can be, well, typically it's going to be unilateral. And We can also have enlargement of our coronary processes as well. Something like this needs to go on for additional imaging and removal. Right. And where do these cases lead? They can lead to orthognathic surgery cases where the entire condylar head has to be removed and replaced with a titanium implant. We can also have malignant tumors, and they're going to cause a lot more profound destruction than we saw with our benign tumors. When we had our degenerative joint disease, sometimes people will get those confused, although I'm not quite sure how, but sometimes they say it's kind of confusing. Degenerative joint disease will have osteophyte formation. They're not going to have this degree of bony destruction. Here's another one. This was a metastatic lesion. So if you're going through and you notice that you're just missing those cortical borders, it means that something has eroded through that. And so definitely we need to go on for additional imaging because we can't see exactly what's going on with our CBCTs. This one came in, this patient had a history of multiple myeloma, and we can definitely see these multiple punched out lesions within the condylar head. So this is our multiple myeloma. All right, so there's a lot of different tools that we can use when we're evaluating. We talked about our CBCTs, but we also talked about segmentation and 3D modeling. And that can help us to further quantify condylar changes, looking at diagnostic changes, evaluating treatment, trying to figure out which treatment may be better, or monitoring the stages of disease progression. And so here's some examples of our 3D models with our bony erosion. So we've got some nice erosive changes here. You can see it really easy with those 3D models, can't you? And this is flattening of that condylar head. We also can look at some of our overlays we have here. You can see the degree of detail that we'll get with some of these. And you can look at it over time. So this was a study done by Lucia Sevedanas where they were looking at orthognathic surgery patients and the degree of condylar resorption. And the mesh is time 1 and the white condyle is time 2. And so these were some of the overlays that we did. We were looking at our different imaging resolutions and our different segmenters, and we were trying to quantify whether we were actually segmenting and looking at what we thought we were segmenting and looking at. So we had optically scanned condylar heads, and then we had our segmented condylar head, and then we overlaid the two to look for any differences. So we were able to go ahead and validate all of this. So where is all of this going in the future? The future of segmentation and 3D printing in TMD hard tissue management is at some point we might be able to re-engineer a condylar head that is anatomically perfect for that patient. And so they have already been able to 3D print a scaffold and infuse it with stem cells and regrow a condylar head. So there's just some really, really great things that we can do with it. Another thing that we might want to do with our patients is we can send them on for MRI imaging. And I'm going to really skim through this because we are slightly out of time. But just real quickly, so you know what to do and what to send on. Our MRIs, basically the patient's put in a big magnet. Radio wave is sent in. When the wave is turned off, the patient will actually emit a signal. And the signal is received and reconstructed into an image. So when should MRI be used? With the assessment of any of our neoplasias, as we looked at, we can evaluate any of the TMJ soft tissues, or when the observation of those soft tissues will actually change the patient's diagnosis and treatment plan. And so this is probably something that we'd love to go over on another day, but definitely we can see the soft tissues of the disc. We can see whether we have an anterior displaced disc or not. We can look at the fibrosis of the retroskeletal tissue, and we can look at joint effusion or inflammation that's going on. What you'll want to request if you're going to send this on for MRI, we like to get a sagittal, closed, and open mouth with both proton density and T2 sequences, and then a coronal closed mouth with proton density. And what you'll get back is something that looks like this, where we have scout views. They're going to tell you the exact orientation of how they've taken it. Usually these have little numbers that correlate to the images that you have. And these are the things that we're looking for. A beautiful little biconcave disc, This is a normal one. You can see that the posterior aspect of that disc is right at the 12 o'clock position, and the patient is closed. The disc is exactly where it's supposed to be. And so we're looking for if we have a normal disc, if it's partially displaced, or if it's fully displaced. And this is what it should look like with the open mouth position. We have fully captured that disc. So we can directly visualize the disc. We can look at the histology, basically, of the disc. The bony morphology, your bone does look kind of interesting with MRI. It's pretty dark, but our bone marrow will be lighter. With our MRIs, we have various sequencing that can help us. So when we're looking at, say, like a sequence like a T1 or proton density, that's great for anatomy. When we're talking something like a T2, that is great for looking at any of our infusions, our inflammation, that sort of thing. So again, these are our normal TMJ, looking at that beautiful little biconcave disc. That posterior aspect, again, is going to be right at 12 o'clock or 11 o'clock position, probably more appropriately. But we can see the disc in our coronal and our sagittal sections. And this is an anteriorly displaced disc with reduction. So when we're looking at it, we can see that the disc is anterior to the condylar head, but when we open, it has recaptured the disc. This is when you hear the click. So if your patient is clicking, what are they doing? They're popping on and off the disc. We can have anterior displacement without reduction. So we have, in the closed position, we can see that we have our nice little, actually looks like it's a wadded up disc, looks like a little gumball here. When we open, it does not improve. And so it never recaptures the disc. It just stays in front of it. We have limited range of motion with that patient case. And of course, we can look at various things. In fact, we've tried to fuse CBCT and MRI. So this is some research that we did years ago. We were trying to get an NIH grant. We suspected in this patient, because we have this intra-articular joint space, that we probably have perforation of the disc on that side. So we combined it with our MRI. The problem being is the MRI does not have the resolution that our CBCTs do. So trying the matching resolution for both of them is difficult. The patient would have to be in the machine for a really long time to get a very fine resolution like that. But we were able to roughly segment it out, and we could see, yeah, we do have a disc perforation. So we could see it with our 3D modeling, which is really cool. So, all right. I know I went over a little bit. I really appreciate your time. This was such a fun lecture to put together, and hopefully you enjoyed listening to it. And so this is when a radiologist takes a selfie. And there I am right there. That's my nice straight nasal septum. So I'm pretty proud, because I know only 20% of the population has a nice straight nasal septum. But anyway, is there any questions?
There is, yes. And can I say, I like that you said we were slightly out of time when you knew we were out of time. So kudos to you.
I am paying attention.
Yes.
It was a very ambitious lecture. So.
Yeah. No, it's very good. Let's see if we can knock out a couple here. So an MRI and CBCT show hard and soft tissue. Is that correct?
That's right.
Okay. Why is it so hard to find a good ENT?
Ooh, that's a good question. And you know what? That's such a good question. There's a lot of turf wars too between oral surgery and ENT. So you could send to an oral surgeon, or you could send to ENT. We tend to work a lot more with ENT, but we work with oral surgeons as well. And what I would come down to saying is, it depends on who is really good in your area. You definitely know, you'll know your area much better, of course, than I would be able to even help you with. And I would say, in your area, if you have an oral surgeon that's just dynamite, send to them, sit down with them, tell them what you're seeing, and ask when they might want to see somebody. Likewise with ENT, but especially at some of our schools, at our universities, we've got some real dynamite ENTs, and all of this technology is geared towards ENT. So they're very interested in what we have. And I think there's just some really nice collaborations, but it can be hard depending on what location you're in to find a good ENT or oral surgeon to send to.
In the case with the bilateral mass noted on the CBCT that needed urgent referral, would you consider ordering additional imaging in the waiting interim period, or would you order a medical CT or MRI?
Absolutely. Yeah. If you can order, I mean, if you're part of like a hospital based group and you can order additional imaging, that's exactly where it needs to go. Um, a lot of our dentists that are out in private practice may not know exactly where to go. So we would send on to, say, ENT or to oral surgery as well, to have that pathway to additional imaging. If they wait for their primary care physician, sometimes that could take a really long time to get into. And so for that reason, I'd want to just go ahead and kind of skip that step and jump right into, either our oral surgery or our ENT. But if you're part of a hospital-based group and you can go ahead and order that, definitely you should order that. CT or an MRI would be fantastic in helping you understand a little bit more about what those tissues are and what's happening. It's a great question.
Has there been improvement in the overall range and dose of radiation between different manufacturers?
Yeah, I would say yes. Overall, in yes. When we did some of the studies that were done when I was at UNC Chapel Hill, and Dr. Ludlow did all of that dosimetry, by the way, they found that some of the CBCT units were up over 1,000 microsieverts. And I believe that unit was taken off the market because of the high dose that went with it. Same thing with medical CTs as well. We're seeing them really come down a lot in dose. Everybody's trying to be careful of dose, and they're finding that they can use these low dose images and correct certain things such as noise just using the various algorithms. And so it's really exciting to see some of these low dose protocols that are occurring. If you're looking at the condylar heads, you could definitely see a difference though when you're, looking at, say, a 0.1 millimeter image resolution versus 0.4 millimeter image resolution as far as the detail that you can see. But then we have to decide how important is that detail for us to see it. If we don't catch a small erosion on day, one with 0.1 millimeter image resolution and we just have a 0.4, what's going to happen with that? Well, the erosion will get bigger and we will eventually see it. And so a lot of the larger field of view are going to be a lower image resolution because we are trying to keep the dose down. So.
All right. Another good question here. Is it standard of care to have CBCT in the office?
That's an excellent question. And that's a hard one to answer, I would just say, because from a radiological standpoint, we always want to promote selection criteria. We never want to say standard of care per se. But there are position papers that are out there. And there's a position paper that came out from the American Academy of Oral and Maxillofacial Radiology in conjunction with dental implantology in 2012. And that one recommended 3D imaging for all implant site assessments. And that CBCT was the imaging method of choice for that. Certainly, we see some of this, of course, pushed from the legal standpoint as well. But standard of care has to do with a particular diagnostic task. So for implants, you might say, yeah, you know what? If something goes wrong and a CBCT wasn't taken for that implant, that doctor may not be defendable as far as the malpractice insurance is saying. So for that particular task, I'm going to say, yeah, that's pretty much moving towards it. As far as for our airway or our temporomandibular joints, I don't think we're to that point yet. Certainly, this is a tool in our toolbox that can aid us in trying to discover what is wrong with our patient. And if that patient comes in pain, do we want to have a CBCT? Is that going to tell us more about what's going on? Yeah, it is going to tell us more about what's going on for that patient. And so we want to take things more of a case-by-case basis. If we want to see exactly what's going on with the osseous stuff, then we want a CBCT. But we have to leave that up to the individual judgment of the clinician. And so from that standpoint, I can't just come out and say something is, blanket standard of care. So.
All right. I think, so many questions here. I find a lot of hypoplastic condyles in my female patients. Should they be placed in occlusal guards?
Oh, okay. It depends on the patient. Again, selection criteria. The patient may have had it their whole life. It might be very, very mild. The glenoid fossa region may have accommodated that over time. So you might see some bony changes within the glenoid fossa region, some adaptive remodeling in response to that. But certainly, it's not uncommon for us to see a hyperplastic condyle with associated osteoarthritic changes. That's a pretty common pairing. And in that case, then, an occlusal appliance will help or may help.
All right, we're going to do 2 more questions. Number 1, if an office takes a CBCT, does it make that doctor responsible for any conditions missed? And then along with that, should most offices send CBCTs out to be evaluated by a radiologist?
So I'm going to say, first of all, what we are responsible for with our images is exactly the same that we've always been responsible for our images. So actually, all of the information in our CBCTs, we can actually see in a pan. So if you're taking pans now, you technically are responsible for everything that you would see in a CBCT, but it's much harder for us to see it because we have all of that 2D superimpositions. So from that standpoint, I would say it's almost better to take the CBCT than the pan because you can actually be able to compare bilaterally what's going on and see what's happening. Ethically speaking, the entire volume does need to be evaluated. So we do need to be looking through our scans. We can't be taking large volumes and then just concentrating on our region of interest. We actually do need to look at it. And if you see something that looks abnormal, then go ahead and send that on. And I know that there are, various schools of thought as far as that goes. Some people say, every CBCT should be sent on for a radiology report. I'm not necessarily going to say that. I didn't go to a school that had that particular thought process. But I do think it's smart to go ahead and document that you have reviewed the CBCT. And so from that standpoint, I would say every CBCT should have some sort of a report. Whether you do it or whether you want to send that out to a radiologist is completely up to you. It depends on your comfort level and what size field of view you have and that sort of thing. But in any case, I would document down that you went through that CBCT if it's not being sent out for a formal report. And that way, if someone were to come back later and say, did you review everything? Yeah, I reviewed everything. Just to make you feel better, the people that are getting in trouble legally are not the people that took the scan right now. It's the people that didn't take the scan. And that's the legal arena that we're seeing, at least here in California, which is one of the most litigious states. If something goes wrong and there's not a CBCT, that's what the lawyers are choosing to harp on, the fact that the CBCT was not taken. Very, very, very rarely do we ever see a case where the person gets in trouble because they took the CBCT and didn't know how to read it. I think there's maybe only 1 or 2 instances that I know of personally, and in those cases, it was blatant. Like, for instance, an implant placed right in the middle of an osteosarcoma. Something we probably should have seen. It's in our arena. So I think from that standpoint, you can feel very, very good about taking your scans, but we do need to look through them. We do need to document that we looked through them. And if you see something that you don't know what it is, then your ethical and legal requirement would just be to send that on for additional evaluation and use your radiologist just like you would for any of your other specialties. So,
all right, last question. Can you diagnose AIDS with CBCT?
I'm going to say no. Yeah, no.
All right.
Yeah.
Awesome. Well, thank you everyone for all of the great questions and appreciate you staying a couple minutes late with us.
Thank you so much. This was really fun today. I really appreciate your time. And Adam, thank you so much for the opportunity to be able to lecture for Henry Schein.
Oh, always, always, always. And if anyone does want to see any of Dr. Kohltfarber's previous webinars this year, I think there's 5 or 6 of them. Please feel free to email webinars@henryschein.com, and I'll be more than happy to send that out to everyone. And then lastly, we did record tonight's webinar, so that'll be sent out the next week. Thanks, everyone. Have a great night.
Bye.